All right, so we're going to get started. We're on the interview and health history PowerPoint. Slide 6 is where we're starting now, and this is just a visual diagram of steps of the nursing process. It involves assessment, diagnosis, which, nursing diagnoses here. There's also medical diagnoses. Basically comparing your assessment with the diagnosis. Outcome identification, planning, your implementation and evaluation. And I won't read the whole slide to you, but make sure to look over this and just become familiar with it. So when we talk about assessment, where are you getting your data from? So you have your patient, whatever department you're in, you want to review their chart. You're going to do your interview, you're going to talk with the patient, you're going to get a full health history from them. You're going to do your full head-to-toe examination, functional assessment, which is, we'll go into more detail, it's assessing how they function on a daily basis and if they're happy with that, their cultural and spiritual assessment, consultation, and review of literature. Promoting a holistic model of health. This is really important, I think, especially for nurses. Holistic means looking at the whole person. So you're not just going in, doing your medical assessment, helping them with their medical problems. You're really looking at them as a whole person and a whole, like all of their needs. So their functional needs, their spiritual needs. When I think about this, I had a patient recently come in. She was 2 days postpartum, and she had had a very traumatic epidural. She hadn't slept since the baby was born, and for about 2 days before that, because she labored for so long. She came in by ambulance with her newborn baby during a pandemic because her husband couldn't care for the child. She didn't feel safe leaving him at home, which is very sad. But she had a severe headache and thought that she needed a blood patch. And I won't go into what a blood patch is, but basically it's a way to get rid of an epidural headache if that's the reason you're having a severe headache after you have an epidural. Inserting blood sterilely into your spine, which just sounds so horrible to me. But she was convinced that this is what she needed, and we had anesthesia come and talk to her, and really she just had a very bad headache because she hasn't slept in days, and she was really struggling to cope with that. And luckily we had the staffing, but really what she needed was somebody to take care of her baby for a few hours so she could sleep, and we give her a lot of medicine and hydration, and I actually spent the last 3 hours of my shift feeding, changing, holding this baby, which I work in an adult ER. This is very strange for us, but that was what this patient needed at the time. She had no coping mechanisms left because she was in so much pain and so tired. And that's what I think about when I think of holistic. It's really like looking at what the patient needs, and sometimes it's not the things that we're used to giving them. So high-level assessment skills, so these require hands-on expertise. So we are going to do the best that we can to teach you all of the basic skills, and the more that you practice them and the more that you do them, the better you're going to get at them. So the goal is you're going to learn as much as you can by reading, listening to the lecture, watching your videos, and then you're going to come into the lab, you're going to practice them either on a sim man or a mannequin or your partner, and then once you go to clinicals, you're going to then use them again. So the more you use them, the more you get help from experts. This is how you are going to enhance your assessment skills. So this is why all of the pre-reading and pre-videos are so important, because I would say, because it depends on what type of nurse you're going to be, but 80% of the things that you're going to learn in this class you will actually use in your nursing career almost daily. Like when I teach this class, these are the things I do every single day when I work. So super important that you take the initiative to practice this as much as you can. Practice it on your best friend, practice it on your significant other, your kids. You know, that's why we got these nurse kits, so you can take this stuff home and practice as much as you can. Now, I believe there's a Foley kit in the nurse kit, so don't use that at home. That's a hard no on that one. Okay, cross-cultural care concepts. Again, talking about the holistic model of healthcare. And really, when I think about holistic with different cultures, it's knowing what you don't know and knowing when to ask questions. So if I'm caring for someone who I believe may have a different cultural background or belief or way that they want to be interacted with, I just ask them, like, you know, I'm not from your culture. I would like to know how you would best like me to address you, approach you. Just being open with them is super, you know, helpful. And even if you mess up, you can at least tell them that you're trying, and they can help you understand how they best like to be cared for. Okay, so our nursing interview here. So subjective data collection. We're going to talk a little bit about objective and subjective in a minute, but subjective is getting the patient's story. It's their perception of what's going on. So you really want to start to build your rapport with the patient. You want to start to build a healthy interaction and relationship, so they feel like they can tell you everything that's going on. And throughout this, you're going to be looking for information or ways you can even give them information to help them take better care, promote their own health, and how they can care for themselves. So different types of data. So objective, these are our observable, measurable, these are vital signs. These are, looking at the patient and you can see that they are pale. That is something that is a fact, right? So that's your objective data. Subjective data is when you're getting the story from the patient. So how they perceive their situation, how it makes them feel, abdominal pain, even diarrhea at home, because you can't see it, that's subjective from the patient. Important to know the differences between these two. Establishing rapport and trust. So yeah, nurses, that's great thing about being a nurse is we're the most trusted profession. So people feel like they can tell us. Oftentimes, I have watched a patient tell me a story and tell the doctor a totally different story. So usually we spend more time with the patient. So we get a lot of the information other people don't. They feel comfortable giving us more sensitive information. So you want to start that from the very beginning. So we're going to talk about introducing yourselves and kind of some good ways to do that. But this is an important piece. You don't want to take care of a patient for 4 hours and if it's an 80-year-old man, if you're a male or a female, if it's an 80-year-old male or female patient, if you're a male, they automatically assume that you're a doctor, which is a little bit stereotypical, but that's what they're used to in their cultural generation. So, things like that. So make sure you clearly introduce yourself and your role and other people in the room, especially if they don't introduce themselves. So here's the question for you. Which of the following would be the best way to refer to an adult patient when initiating the interview? Hello, Mr. Jones. What brought you to the emergency department today? Or number 2, hello, James. What brought you to the emergency department today? Hi, I'm Nurse John. What brought you into the hospital today, Jim? Hi, Mr. J. What's up? Why are you here today? So think about that, and then think about which question you think would be the most correct. This is sort of like an NCLEX question. They're giving you a better answer, but it's not the best answer. So the answer for this one would be 1. So I think the best answer, I always start out by asking the patient their name, right? Because I'm bringing my patient back to a room, so I call their first name and then I ask them to confirm their name and date of birth to make sure I'm grabbing the right patient, and then I ask them how they like to be addressed. And then I say, Hi, my name is Jessica. I'm going to be your nurse while you're in the emergency department today. What brought you here? Um, so you want to kind of get your own way and flow of going through that, but you want to make sure you're addressing them appropriately, making sure they know who you are, um, and then starting to get their story. Techniques of communication. This is really important. You want to ask open-ended questions. So you want to stay away from, unless you're asking specific, you want to know specific things like their immunization status, things like that. But when you're asking them about what's going on, um, you want to give them an open-ended question. So you don't want to ask them yes or no questions. And then you can ask some more, like you can ask clarifying questions, or if you feel like they are going to tell you a big long story, if you have time for that, then you want to stay quiet and let them go through all the things that they want to say. If they sound frustrated, it's okay to empathize with them. Like, it sounds like you're frustrated, that's okay. I'll let you read, this is the Techniques of Communication, slide 15. But you can read through all these things, and what I like to do is at the end of my assessment, I will summarize what I heard from them, because oftentimes patients, they get focused on one thing and they forget to tell you another, or they're confused. And so I summarize what I heard from them, and that way they can correct me if I've misinterpreted anything. 10 traps of interviewing. These are just things I would not recommend saying. Um, you know, false reassurance, like, oh, you'll be fine, or you'll be okay, I'm sure you'll be okay. There's better ways to say things like that. And so you can read through these. Professional jargon is one that is super important. So even if a patient is medical, when they're in a time of crisis and they're in the hospital, you don't want to use professional terminology. I was working with a new nurse, and it was really busy, and I was helping in a room, and this patient was really sick. I was hanging some fluids, and this new nurse came in. She'd been a nurse maybe for like a year and a half. I was actually very surprised by this, but this patient had been a little bit challenging. But she walked into the room and she said, "Okay, hon, I'm gonna drop a Foley," like that, and then started sterilely opening the Foley kit. And I was so caught off guard. I was like, well, a non-medical person has no idea what drop a Foley means. Also, very unprofessional to say that in front of a patient. So I didn't want, you never want to correct or embarrass another colleague in a room or say anything. And so, the patient kind of like wide-eyed, like, what do you mean? And so I calmly explained the procedure. I was like, oh, well, since you're very sick, and we really need to monitor your fluid intake and how much urine comes out of your body, so how much you're peeing all the time. We need to monitor it, and it's a catheter that goes in your bladder, and it will drain your urine so we can monitor it. And she had been previously sexually assaulted. She was very upset and stressed about this catheter, and so we just talked through it, and but I had to explain detail by detail. So really think about how you're talking with your patients. I don't remember what they say, but like, even when you're giving patient information in a hospital setting, they say they only remember it's like less than 10% of what you say. So making it as simple as possible for them to understand. You don't want to use bias questions, like, if a patient has COPD and they've been smoking for 60 years, they very much know what they've been doing to their body, and you don't want to say to them, you don't smoke, do you? You don't want to make them feel bad, because that's a really quick way to lose trust for your patients. So just letting the patient talk and assuming, just not making them feel bad, and just doing the best you can to help them give you all the information they can. see here. So developmental competence, when we're, if we have a patient who is nonverbal, um, or it's a newly confused patient, you want to make sure you're getting history from the family member, um, or the caregiver, and making sure you're asking the right person. So you want to make sure this patient, if they are in a mental state of mind to give appropriate consent, you want to make sure they're okay. With you talking about health history with another family member. But it's okay to ask the family member in the room, how their perception of what happens. So that is really helpful when, especially if the patient's confused or they had a stroke, you want to get as much detailed information about the incident from the family. And then, when you're talking, depending on what type of nursing you choose, talking with a toddler is a very different event than talking with an adult. So if you're doing a lab draw or some sort of procedure, you're not going to walk up to a 3-year-old and say, okay, I'm going to draw your blood, sit down. You're going to find other ways to distract and tell them what's going on. Like there's going to be a little pinch, and there's ways to talk through it. It's been a while since I've taken care of kids, but I'm just knowing that you don't talk to different age groups the same as you would. You don't talk to a toddler the way you would talk to an 80-year-old. Interviewing people with special needs. This is very common in medicine. So, are they hearing impaired? This is hearing impaired. There's a big community in Portland of hearing impaired people that really don't want a video interpreter. They don't want they want an in-person interpreter that they feel comfortable interacting with. And so depending on your work, different policies are in place, but really if you have a hearing impaired person, especially if they know if they're deaf, you want to always get an interpreter if it's necessary, an in-person interpreter. And for your acutely ill patient, they're not going to want to tell you their full health history if they have, severe abdominal pain from appendicitis and have a high fever. You want to really focus on the important information that you need to care for them in that moment, and you can get the rest of that information later. If any of you end up in the ER or mental health under the influence of street drugs or alcohol, these are very difficult patients to deal with. So, not getting caught up in that argument of, what they should or should not be doing with these patients. Personal quote, you don't want to share too much about yourself. It's okay to be friendly and kind to your patients, but you don't want to give them a bunch of personal information because, there are some not safe people out there. Sexually aggressive people, so if you notice this, you really maybe want to remove yourself from the situation and discuss safety measures. Get someone, if it's a man that's sexually aggressive to a woman, maybe you need to get a male caregiver to help you in the situation. Crying in anger, these patients, they could be crying because they're in severe pain. Some patients are very histrionic and they feel like if they're over the top with anger or crying, they'll get more attention or more of the things that they need, and that's kind of a sad way to talk about it, but it's kind of the reality of being a nurse and caring for some difficult patients. And patients with anxiety, patients with anxiety have a really hard time, they're often focused on one thing, and you really need to help them through that before you can get to the next assessment step. So aspects of culture to consider, gender, making sure you're using the appropriate pronouns, so you want to ask them about that. Sexual orientation, so often this does not matter. If the patient is comfortable sharing, that is fine. I wouldn't push this as a question. And with gender, if it's not imperative to your assessment or to the care of the patient, then it doesn't matter, what you want to know their pronoun and respect the way they want to be addressed. But if you don't need to know their reproductive organ status because that doesn't affect your care, that's not something you need to discuss with them. And just to be aware of that and be careful with the way you discuss. You don't want to ask questions because you're curious. You want to make sure it's pertinent to their medical treatment, and you want to make sure that in that you're telling them why it's important. So if it's a patient who is there for lower abdominal pain and they need a CAT scan and they identify as a male, but if they still have a uterus and they have all the reproductive organs to potentially have a pregnancy or something that would affect those tests, then that's something you need to know. You need to describe that to them and explain that to them. That's really important. Etiquette, space and distance, and again, that's where you just go back to asking the patient what is the best for them and what they prefer. So communication barriers, so working with and without interpreters, I would say always get an interpreter. It's really important that you are getting the appropriate communication. So it's if you're asking the patient questions and the partner or whoever's in the room just keeps answering for them, over talking them, you really want to be clear and be like, thank you so much. I just really want to hear from the patient directly so I know how they're feeling. You want to be kind about it, but you want to just set those expectations. But working with an interpreter, super important. You talk to the patient. You don't want to talk to the interpreter. You always want to be clear and discuss with them directly. You never want to use a family member as an interpreter. If it's an emergency situation and this is the only way to get communication with them, then fine, you're waiting for an interpreter. But when in doubt, always have an interpreter for the patient's safety and your safety. Okay, on to the complete health history. So, biographical data. So this is a very, very, very detailed health history, and I apologize if my emergency department bias comes through every now and then, but it will happen, and I apologize. So source of history, why they're seeking care, biographical data, and I think to myself that's not important, but then I took care of a patient the other day who had recently flown here from Florida on a packed flight coming from a city that had, all of the COVID. And so that was important because he was like, oh, by the way, I've had a cough and I just flew from Florida. So that made me, that's a different, right now I'm concerned that he might have COVID. So different precautions for this patient. So there are reasons why it can be important. Or if they're coming from a place that is, known, if they're flying from a place known for malaria and they're there with a fever. So those are reasons things like that are important. Why they're seeking care. So is it the primary care? Are they in the ER? Where are they? Urgent care? And what made them finally come? A lot of times, I'll take care of patients who they've had abdominal pain for 6 months and then they come at 3 a.m. And, my question to them, and not in an accusatory way, but like, how come, if your pain's been going on for 6 months, what happened at 3 a.m. that made you think like this is now an emergency? So oftentimes, the patients can say so many different things. So they just realized, or they just got tired of it, or it got worse tonight, or there's some. You want to know the reason, because if it's been going on that long, you really want to know what made them eventually come to the hospital. I had a patient, she had some lower abdominal pain, and she had it for like 24 hours. And she, it seemed like very mild, not too bad. But she tried to take some ibuprofen to see if that would help, and then she vomited. And so when she vomited, she got nervous that maybe she had some sort of like diverticulitis or appendicitis or something like that. So it ended up just being gas and she was totally fine. But, you know, you want to know the thing that pushed them to seek care. Um, you want to ask them about their health, their health history, you know, what illnesses do they have? Do they have diabetes, high blood pressure? Have they ever had surgery? Especially if they're coming for abdominal pain, if they've already had their appendix out, you know, that's a really important piece of information so they don't get worked up for that. Family history. Family history really comes into play when it comes to things like cardiac disease. You know, if I'm a 30-year-old male, but my father died at 32 of a massive heart attack, um, and I'm coming in with chest pain, that makes me a lot more concerned than if I'm a 30-year-old male, but my parents are healthy and I'm healthy and fit and a good, you know, that to me, those are different levels of severity. Review of systems, that's just doing your full head to toe functional assessment, including activities of daily living. When we talk about functional assessment, we're really, so I think a good example of this is a stroke patient. So say I come in, I'm having this weird like numbness in the right side of my face, and my right hand doesn't work anymore. And so they find out it's a stroke. It's not bad enough to require any. It might not require any intervention, but then, you know, in doing the stroke assessment, you find out that my job is I'm a violinist, and that's my career, that's my livelihood, that's my passion. So I might be a person that, even though I'm having very, very minor symptoms in stroke, that I might need to, I might want to go get the procedure to get this stroke, the clot removed from my brain to help get functionality back to my hand, because that's everything. Whereas, you know, if it's, you know, someone who they're left-handed, they have no problem, nothing that they do in their daily life needs their left hand, and they can maybe do some physical therapy, maybe they won't go through with the next procedure. So that's an important piece when you're looking at disabilities like that. On to biographical data. So most places now, this is actually done by somebody else, like that's checking the patients in. But you may work in a rural place where you take all the information down. Really important to have a follow-up phone number for patients. This is something I will, even if it's in their demographic information, I will actually take their phone number down and put it in their chart and highlight it, because if we need to call the patient back, or if they forget something, or if a test result came back that we weren't expecting, this is where you want to be able to get a hold of them, right? So always good to get contact information, even if it's already done by somebody else. I'm not going to read this whole slide to you. You know, occupation, I usually like to ask this, especially if they've had an injury, or, you know, whatever their illness is going to affect their daily life. I want to talk to them about whether or not they can go back to work and how that's going to work for them. And really important that you're documenting the patient's primary language, and if they require an interpreter. So their primary language might be Spanish, but they might speak fluent English. But you want to ask the patient, you know, like what do they prefer, and do they not want an interpreter? Okay, so sources of the history. This is where you're getting all the subjective information. So right, it could be a friend, interpreter, relative. You want to document all of that. And you know, if you feel like you want to talk about if they're reliable, and if you think so, they're, you know, they're answering one question and then answering the same question very differently at a later time, you want to make note of that. I often will check patients in that come in by ambulance, so I'll make a note that says patient brought in by EMS, by AMR, and then I'll talk about what the EMS statement says. So the you know, paramedics reported they arrived and found this patient down on the ground, and then kind of the story of what happened. And then I'll make a note from the patient's point of view if they're able to give me history as well. So important you're writing and documenting who you're getting the information from. Use of patient's child as interpreter, we already talked about that. I would say never unless you are in an emergent situation. So, okay, so your chief complaint. So, like the abdominal pain patient, right? So there you want to, so for me, we do chief complaints. So for the abdominal pain young girl, that I would put abdominal pain, nausea, vomiting. Those would be her like main complaints. And then I would say, you know, patient arrives to emergency department complaining of left lower quadrant abdominal pain since yesterday at 2 a.m. Also complains of nausea, had one episode of vomiting. And because it's COVID right now, I would also say patient denies cough, fever, shortness of breath, and is wearing a mask, right? So that would be my kind of initial, and that's the thing that people are going to read initially to determine in the ER, especially like where she's going to go, like what room she's going to go to and who's going to see her. So, yeah, so that would be the subjective chief complaint. Yeah. Present health or history of present illness. So this is, we're asking, so I'm asking the same patient, where is the abdominal pain? She's pointing to her left lower quadrant. So I'm documenting left lower quadrant, and I'm asking her, is it icky? Is it sharp? Is it throbbing? Well, in the pain assessment slide, we'll go over all the different types of pain identifiers. But, you know, quantity or severity. So now on that scale of 0 to 10, how bad is the pain? 10 is, I would say, if you're being run over by a semi-truck, that's a 10. A 0 is no pain at all. I kind of ask them on that scale. Timing, when did it start? Does it come and go? What were you doing when it started? What makes it better? What makes it worse? And like, what were you doing when it happened? When you get the pain, do you also get nauseous? Or, you know, I would try and ask it in a more open-ended way. So when you get the pain, do you have any other symptoms? And then I always ask, like, what do you think is going on? Like, has this ever happened before? Do you know what it could be? What are your concerns? Because you can learn a lot of information, because you know, you can go through all of these assessments, and then I'll say, you know, well, what do you think is going on? And the patient might say, well, I've had an ovarian cyst in the past, and it feels exactly like that. You know, even though you ask them all their medical history, and they never mention the ovarian cyst. So, PQRSTU mnemonic. So, I automatically do this in my brain now, so I don't use this mnemonic anymore. But I would highly recommend you memorize this, and every time you're assessing pain, you are going through this mnemonic. So provocative or palliative, I kind of just went through all these, but what makes it worse? What makes it better? Quality or quantity, so that description, aching, throbbing, stabbing, shooting. Where is it? Does it radiate anywhere? How bad is it? You want to use that 0 to 10 scale. When did it start? Just come and go, and then asking them what they think is going on. Okay, past medical history, we kind of went through this a little bit already, but, you know, were they a healthy baby? Did they have any injuries? Have they had any accidents? You know, I work at a trauma center, so often a patient will be like, oh yeah, I was shot 3 times in my leg 5 years ago. It's weirdly very common where I work, so because they come back to the place where they went when they got shot initially. So ask them if that's related to what's going on. Do they have any chronic illnesses? Have they ever been hospitalized, had surgery? OB history is really important. We'll go over this more later on when we go over the abdominal GU lectures. But you want to know, have they ever been pregnant? How many babies do they have? You know, were those healthy? Could they be pregnant now? Immunization status. Childhood immunizations can make a different diagnosis for a patient when they come into the hospital, especially if they have a rash or a fever, and they've never been immunized for measles or something like that. The last time they went to the doctor. Allergies to medication, super important. You don't want to give a patient a medication that they're allergic to. So medications they're allergic to, environmental allergies, food allergies, really anything that they're allergic to. One thing to note here, you always want to put what their reaction was. So they might not know. You can say unknown, but if they had penicillin one time and they had anaphylaxis and had to be intubated, that is a very severe reaction. If they had penicillin one time and got nauseous and vomited, that's probably something you could work through, or if they really needed penicillin, you could maybe find a drug closer to that class or in that class. Another thing to note with shellfish is if they're allergic to shellfish, you don't want to use iodine because there's iodine in shellfish, so sometimes that can be the allergy. And then you really want to get a full medication list from them, which can be very difficult for patients. Sometimes people are not the best historians. Okay, family history. We talked a little bit about this already, but these are things you want to ask them about that could be affecting them. Were they adopted? Did they know their medical history? They might not. Genograms. I'll let you go over the slide on your own. In your health history assignment, you will be doing one of these, so this just kind of shows you their family history. This is, when you're a primary care provider and you're doing the full health history, this is very in-depth, but you want to look at their what things they could be looking, diagnoses and things like that they could be going to have in the future based on their family history. Review of symptoms and systems. This is just a list of all the things you're going to learn to assess this semester. Functional assessment. So here we're talking about, how they're, whatever's affecting them, how is it affecting their daily living? So are they healthy? Do they sleep well? Activity and exercise? Do they have all the things that they need to go home safely? Are they safe at home? Do they have an occupational health hazard? These are the things, that's when we're looking at the holistic patient, when we're really trying to get down to it. I had a patient not too long ago who came she had a surgical procedure on this very deformed arm, and she had cerebral palsy, and she had come from the psych facility because she was suicidal, or she wasn't suicidal, she was depressed and wanted resources and had some vague suicidal thoughts, but they sent her to us because she had an abscess in this surgical site, and we drained the abscess. It was no big deal, and I asked her if she wanted to go back to the psych facility, and her mom is her caregiver because she's in a wheelchair, and she goes, no, I really needed to get away from my mom for a few hours. So I helped her. I got her some food. I let her, get all the resources that she needed from our social worker, and then we were able to get her home when she was feeling a little bit better. So things like that you don't really think about when you become a nurse, but functional assessments are really also very important. Okay, this is your alcohol assessment test. I'll let you read through this and go over this, but do you think you need to cut down? Do people annoy you about your criticism of your drinking? Do you feel guilty? Do you need an eye opener? And that's the CAGE. And that's kind of giving you the assessment that they may need some resources for alcohol abuse. A more commonly used one is the SBIRT screening now that you'll see, and that's the questions if you've ever gone to your primary, they're going to ask you if you've had more than, I can't remember how many, it's like 4 or 5 drinks in a day if you're a woman, and it's like, I think it's more than 4 drinks in one sitting if you're a woman, and more than 5 if you're a man, or if you've ever used any illicit drugs. And if you say yes to any of those, you basically flag positive, and then you need to get resources or talk to someone about the help you can get. This is, so perception of health, we're going to talk about, you know, how they define their health. So if, you know, that COPDer that's, you know, 60 years old and been smoking their entire life, they probably don't want to quit smoking, and they're probably just going to keep smoking, and they're happy with it. They like to do the things that they do. They feel that they don't need to come to the hospital that often, even with how much they smoke. You know, so asking them what their goals are, because it might be very different from what you and I would perceive as something healthy. Assessment of the child. You know, so assessing a child is very different than assessing an adult. It's a little more tricky to get information from them. The parents can be very helpful, or they can be very not helpful. So like a pain scale is going to be very different from a kid. You're not going to tell them 1 to 10. There's, on slide 37, there's an example of a pain rating scale. The Oucher was listed somewhere. I've never seen that scale actually, but I included it here just in case that's something you encounter. The Long-Baker Faces pain rating scale is really the most common, and so you show this to the patient. You can put it on your badge, or you can have it on the wall, and you just ask them to point to the face. You know, if their tummy hurts, you can say which face matches how your tummy feels. You know, and that's how you get a pain assessment on the kid. This is, you know, for adolescents. These are the things you would want to assess for adolescents. For older adults, you're going to really want to talk about their activities of daily living, or their ADLs. What's important to them. So what things do you want to focus to help them accomplish? Like, is it really important for them to go on a walk every day? You know, and how you can help them get to that goal. And current medication. I mean, some of these elderly patients are on so many medications, you know, that because there's one for their heart, and one for their cholesterol, and one for their blood pressure, and this can cause a lot of problems. They can pass out, they can get lightheaded. So really discussing all of those medications. Religion and spirituality. This can really affect patients. You know, it can affect their ability to receive care. It can affect their how they want to be cared for in the hospital. Almost every hospital I've ever worked in has a chaplain or something that can help you if they want more resources. Certain places, like if you work at Providence, anytime there's a critical situation, the chaplain automatically comes. You know, and a patient might be, you know, agnostic, not religious at all, but you know, their role is actually just to help them with kind of anything that they need. They don't have to be spiritual at all, but just knowing that this can play an important role, and how it can affect your own personal bias. So for Jehovah's Witness patients, they don't accept blood transfusions, which when it's a life or death situation, knowing if they got a blood transfusion they could survive, you know, how do you personally cope with that? There are some bloodless surgery programs now that seem to be helping, but you know, just thinking about what your response is going to be. You want to think about your own beliefs and biases, and then you don't want to put those on the patient, but you want to ask them what they need, and then assess how you can help them and get people to help intervene. So this is quote here: we do not expect clinicians to perform appendectomies, and we shouldn't expect clinicians to be expert spiritual guides. We can be the mediators of spiritual resources for those that we serve. So we can help them get the resources that they need. Okay, I am going to end this lecture, and then there's 3 more shorter videos I'll probably combine into one. So